So, good morning, everyone. My name is Caterina Lombardo, and I am a program lead in the SBRI healthcare team, and I'm going to be your host today. We're going to talk about our shiny, new, exciting call for the SBRI healthcare program, which is going to focus on antimicrobial resistance. So, if we go to the next slide, I wanted to say I won't be on my own today. I will be joined by our SBRI healthcare team, who is going to talk about a little bit more about the program and how we're going to address this call, how you can apply, what's the assessment process. And then we have two special guests. We have the National Clinical Director for Infection, Antimicrobial Resistance and Deterioration, who's going to talk a little bit more about the challenges in AMR and what we're trying to address with this call. And then we're going to have a guest from the Health Innovation Network who's going to talk about their role and how they can support you. And we will have a couple of opportunities for you to ask questions to our guests. So if we move on to the next slide, please, before we kick off, I just want to say a couple of things. Talking about questions, please do use the Q&A box. I won't be looking at the chat, so I might miss your questions if you ask them in the chat. So use the Q&A box to ask all you need. Also, to let you know, the National Clinical Director will have to leave after the first Q&A session. So please do make sure that you ask questions to him related to the remit then. And if you instead have a technical issues, please use the chat. And yes, this event is recorded. And yes, the slides and the recorded will be shared. But if you don't stay with us today, you will miss the opportunity to ask questions to our speakers. So I would encourage you to stay in spite of that. And you will see our contact details throughout the day, but do feel free to reach out after if you have any questions. And I think that's all from me. Next slide, please. Yes, so I'm going to introduce you to the first speaker, who's Dr. Michelle Eady. She's a senior program manager in the SBRI healthcare team, and she's going to talk about the call and give you more details about why we're here today. Over to you, Michelle.
Thank you. And thank you for the introduction. Next slide, please. So yes, as Katerina said, I'll tell you a little bit about the SBRI healthcare program. For those of you not familiar, SBRI stands for Small Business Research Initiative, and SBRI Healthcare provides funding and support to early stage projects, enabling testing for technical and business feasibility and technology development. And we also support more mature products through real-world implementation studies. The programme is funded by the Accelerated Access Collaborative, or AAC, and is supported by the Health Innovation Networks. Through the funding and support, we aim to improve patient care, increase NHS efficiency, enable the NHS to access new innovations, and solve identified challenges. And we're also aiming to bring economic value and wealth creation opportunities to the UK economy. Next slide, please. So this webinar is specifically about our phase 1 AMR call. As you can see, SBRI funding spans across the development pathway, and this particularly is targeted at early stage projects. Next slide, please. So we provide 100% funding for our applicants. We're a risk-oriented programme. We aim for a simple application form and quick turnaround, and always open to feedback if there's any way we can improve this for you. And as mentioned, we are supported by the Health Innovation Network. Next slide, please. And on that, this is just an image of the Health Innovation Network and the regional hubs, but I won't dwell on this as we've got Rusty to speak about this later. So next slide, please. We run themed competitions to address identified NHS priorities. And as mentioned, we run our competitions targeted at early and late stage. although we are just talking about early stage today. We're particularly suited for SMEs due to the rapid contracting time, but we are open to any size organisation based anywhere in the UK or Europe. We just ask that there is a route to market plan. So at this stage, we run a phased approach. So initially, you'll be applying for a phase 1 award, typically a feasibility project. So these are 6 months, and you're able to apply for up to £100,000 net. If the phase 1 is successful, subject to budget, you'll be invited to apply for a larger phase 2 award, which is 12 months and typically up to 800,000. Next slide, please. So to go into a bit more detail as to what we're expecting to see, phase 1, we're fairly open to anything so long as it addresses the challenge brief. So innovations such as digital health and AI, medical devices, in vitro diagnostics, behavioural interventions, service improvements. And we say there's no set entry point for phase 1 applications. We do find those that are competitive typically have at least some evidence of proof of concept, but that isn't necessarily a requirement. And these phase 1 projects are typically addressing technical and commercial feasibility. So if you go on to the next slide, and I'll go into that in a bit more detail. So the activities that will be involved within your phase 1 project depend on the stage of development that your particular innovation is at. But just as an example, these are some examples of expected exit points. And don't worry, you're not obliged to do all of them within your 6-month project, but they're just some examples of what you might expect to do and what might be achievable. So for instance, feasibility studies, market validation, develop your business plan, identify your clinical partners for potentially the phase 2 study, develop your PPIE strategy. So we would expect there'll be some patient and public involvement and engagement at this stage, but that can be further developed through your phase 1 project. Again, conduct health inequalities impact assessment and develop your plan to support the NHS to achieve its net zero ambitions. And we've got some examples of phase 2 there as well. And next slide, please. So this is just a snapshot of where we are. We've supported 330 projects with over 150 million invested. And if you do want to find out more about our innovators or have a look at case studies, we've got some examples of these on our website. Next slide, please. And this just shows you a really nice snapshot of some of the organisations we have supported over the years within our different challenge areas. And next slide, please. Then looking at the impact, those projects that we do fund do go on to great things. So you can see here there's a lot of private investment that has been leveraged from those 330 projects and 150 invested. There's also been growth to the organisations with a number of jobs created. And most important for us, this has impacted on a large number of patients, either through the trials themselves or subsequently through sales. Next slide, please. So we offer our applicants support throughout the process. So we hold webinars such as this, allowing opportunities for questions. And then once you're on our programme, we do offer the NICE Meta tool to phase 1 and 3 applicants. And we have various webinars during the progress to support you on your journey. Then once your project finishes, we don't forget about you then. We have a number of events and webinars that we do run that you may be invited to. And we're always interested to follow the progress of our projects and showcase the impact that they're producing, either via case studies on our website or the annual report we present. And just at the bottom there are a number of the organisations we've worked with. Next slide, please. So I won't talk too much about the specific brief for this competition, as we've got Matt far more qualified to talk about this, but just to note, we have 4 sub-challenges outlined under this competition: point of care diagnostics, monitoring susceptibility testing, prescribing decision support and risk stratification, novel care delivery methods, and infection prevention control. And there's a few links there to our webpage, the challenge brief, and our guidance for applicants. And as Katarina mentioned at the start, these slides will be available after the presentation with the various links included. So on that note, I shall hand back over. And please do add any questions in the Q&A as you go along. Thank you.
Thank you, Michelle. And now I'm about to introduce our first guest, which is Professor Matthew Inata-Kim, National Clinical Director for the specialty, but also acute medicine consultant at the Royal Hampshire County Hospital. And Matt is going to talk a little bit more about the clinical details of the ambition that we're trying to reach with this call. So over to you, Matt. Thank you for joining us today.
Oh, thanks so much for the invite, and hello, everyone. And thank you all for considering joining the fight. So as Katarina says, I'm a jobbing clinician, really, as a day job, and I'm used to the full train carriage of patients arriving in hordes, in queues, sometimes overwhelming the system. And when you look at the average medical intake, around half have a suspected infection, if not more. And this proportionality is only growing over time, even in a hospital setting. So what we do today, what we talk about, is so important for the future safety, resilience of the NHS going forward, and indeed for patients. We know patients are not as happy with the NHS as they once were for a variety of reasons, and it's our job to try and bolster that confidence and satisfaction with the best we can do in providing care, but also their technology and research behind that. There are many different modalities of treating patients that are coming up all the time. We're learning more about patients and care through the use of big data. And there are massive opportunities as well as challenges in this arena about how we work more effectively to redress the huge inequalities we see in healthcare, particularly for those living in areas of deprivation, and how we bring together the triumvirate of our expertise from a clinical perspective, what patients want in personalized care, and the best evidence possible. It's only really by combining all of this that we're going to, I think, make all the inroads we can. There are wonderful ideas within these documents about where we need to invest the money, and it's been a really well thought through process, thinking about very large scale things, complete system redesign regarding infection care, the clinical pathways and decision-making points, the use of diagnostic tests, particularly in a point of care setting, big data and how we can best use that, and the importance of prevention and preparation. If we think about the National Action Plan's priorities, the 2 main ones that have, I suppose, most clinical interest sit around this idea of infection prevention and management and antimicrobial stewardship and how they are utilised, with a huge amount of other elements to do with global health, but also the One Health approach, thinking about agriculture, farming, dentistry, other elements that are really, really important. But we're here today to really focus on the prevention and management element and the stewardship side of things. In terms of the yin and the yang of what we see in everyday clinical practice, we're often between a rock and a hard place as clinicians and as patients of not wanting to have antibiotics to the point where we become resistant to them, but sometimes absolutely requiring them. And nowhere embodies that better than in the care of septic patients, where we are incredibly worried about patients dying. And therefore, there is a precedent for giving antibiotics early rather than just waiting when there is a sniff or a concern. But it's getting that balance right of trying to avoid just in case prescribing against using clinical judgment, using the best available clinical tests and the best evidence clinical pathways. We need the balance to be right between those 2 conditions. And considering one in isolation is not going to get us to where we need to get to. This is about a balance between the 2 and ensuring equipoise between infection and antimicrobial resistance, sepsis and antimicrobial resistance, and the consideration of prevention along that pathway. Infection sells itself, really. It's a bit of an open and shut case in terms of the sheer scale and burden. The top left graph shows the growth of infections over time relative to the emergency intake. And now, as I said, we're nearly at half of all emergency admissions are due to suspected infection. When we look at the top reasons for an emergency department attendance, again, suspected infections out-attend every single other cause, including more trivial things like a finger laceration or a sprained ankle. And indeed, there are probably around 6 or 7 times more infection-type presentations than there are acute coronary syndromes or cardiac emergencies, which I think shows you the scale of where we've got to as a species. No longer are heart attacks, for instance, our biggest presenting problem within an emergency sector. It is infection. And yet, when we look at the infection budgets for improvement, for research, and for system-wide change, they're a tiny fraction of potentially more other established work streams. Looking at the total proportion of NHS hospital deaths, 2/3 of patients dying in an inpatient bed do so because they've come in with a suspected infection. 1/3 of inpatients are on an antibiotic at any one time. This is the scale. When you look at the bed days occupancy, again, it's nearly half. The green represents infection bed days compared to everything else. So there's huge opportunity to not only understand the scale of the burden, but also think about the opportunities to improve care and to ensure that we optimally manage infections in all settings, because it's not just about the hospital. There's an increasing growth, and this is why the growth is happening, with now up to 4% of all emergency admissions classified as being immunocompromised as a group of patients. We are getting better at keeping people alive with immunosuppressive treatments, with all sorts of other complex interventions that mean frail, elderly, comorbid patients are surviving. And unfortunately, we haven't cured mortality. Patients do succumb to something and they do get sick with things, and you can't prevent away all illnesses, and you certainly can't prevent away all infections. So our ability to manage infections for these sorts of categories is incredibly important. How this tapestry all works together in my head revolves around these 4 main buckets, thinking about the prevention angle, but also incorporating preparation, presentations and how people become sick and how we respond to that sickness, the acute care provision in community settings and in hospital settings, and then the outcomes themselves. People sit on a spectrum between fitness and frailty, with a variety of different conditions that underpin where you put people on the scale. Immunosuppressed patients are a law unto themselves. They are not really defined in a standardized manner at NICE or indeed across organizations. And that's an important thing we need to get a grip on going forward. But the whole sort of gamut of fitness and frailty is important to understand where patients sit in terms of risk. And then what you can do from a prevention perspective to best optimize their chronic diseases to reduce their chances of infection. Diabetes is a good example. Good glycemic control is a good way of preventing infection. Good foot care, for instance. And then you have to think about preparation, because despite the best prevention you can possibly put in place, sometimes infections break through. Imagine the patient on chemotherapy with aggressive cancer drugs. They are going to become immunosuppressed and neutropenic at one point or another, and they will succumb to an infection at one point or another. So it's how you prepare that patient for the future. Thinking about how symptoms develop, what develops, and how patients are instructed to respond to them is really important as well. Patients should have a thermometer. Patients should have an oximeter, in my opinion. And therein lies an opportunity for monitoring patients, particularly with chronic illness, but also those particularly at risk of infection. And then the elements of acute care surrounding what we can do better in terms of access, assessment, capacity, workforce, scoring systems, decision-making tools, the diagnostic tests that I think are a real game changer, treatments, monitoring, and then the linkage with electronic systems. So although you have a non-admission and admission as an overall outcome, there's a huge amount in between: independent recovery, dependent recovery, death. And then the upshot of all of this, which I guess is whether you go on to develop antimicrobial resistance in one form or another. Data is going to be king here in terms of understanding this pathway at scale across entire populations. And then underpinning the outcome, we then have the opportunity to get in and do more prevention, more disease-modifying elements to try and reduce future infections and the severity therein. This is going to take massive redesign of systems across the scale, thinking about primary care, the workforce, deprivation, urgent care, and this crucial concept of same-day access for patients, particularly in areas of deprivation. The growth of infection and the preponderance of bad outcomes in those living with deprivation demand this. There are areas of deprivation where there are double the number of admissions, double the number of deaths, and double the number of bed days relative to more affluent areas. We should not tolerate this any longer. It's not acceptable. But to get into that deprivation scale, we have to understand what it is that's causing it, what's driving it. It's multifaceted. And the core 20+5 is getting to some of the chronic stuff, but it's not touching the acute stuff. And the acute stuff is what patients feel when they get sick. How do they present? What is their access like? How ready is the system in different parts of the region, and particularly in areas of deprivation, where we know the demands on emergency departments are significantly higher than in areas of more affluence. We have to deconstruct the pathway and think honestly about how patients get sick and how they are triaged at the community stage, and what the Sankey flow shows us in terms of the proportionality of patients who present in hospital settings and community settings. What is our opportunity for remote assessment? What is our opportunity for virtual care? How can we invoke urgent community response, assessment hubs, home visiting? And then what are the outcomes therein? Understanding that then gives us an opportunity to plug resource where it's required. And with that, to help define what a real red flag type pathway is. We think about patients becoming sick, not only in institutions, but in their own homes, and then thinking about where primary care is headed and where potentially alternative structures for dealing with urgent deterioration in community settings are established, particularly in urban settings. Should there be a same-day access kind of centre for patients becoming sick that mean they get same-day access to healthcare? And could suspected infection be a good example of where we can really break the model? Infection hubs already exist now. There were 363 a couple of years ago that were funded. Now we're still up to about 200 to 250, seeing upwards of 700,000 patients per winter. Things are changing, but what we need to support them are understanding exactly what we mean by infection. What are the symptoms? What are the red flag symptoms? How can we best invoke a pathway that defines who should be seen where and with what level of acuity? And where is the place for diagnostics within that? Treatment, self-monitoring, and how do we pull all that data together? The hubs example was a good one. So it was thinking about how we do that triage process and bring in all those other elements of care, treatment, and investigations to invoke best outcomes for patients. As I said, the funding dried up, but a lot of ICBs decided it was the right thing to do anyway, have continued. And the question, I suppose, is how we leap on those opportunities from a research perspective. Suddenly, in community settings, we have that ability to put in standardized pathways at scale and potentially have sustainable means of doing point of care testing, again, at scale. This is a gift horse. In small primary care practices, it's very, very difficult to establish those sorts of questions and answers. But at scale, if you're looking after 250,000 patients per hub, then you've got your opportunity. And that breeds that question of what tests do we need, diagnostics, what the sharp end. And for me, it revolves around these three main areas. One, virus versus bacteria. Two, pathogen identification, which can sometimes be fairly delayed. And three, illness severity. If I had to put them in order, I'd probably want the differentiate viral, bacterial, followed by illness severity. The pathogen identification at the moment is a bit hit and miss. Just because you don't have a particular organism, it doesn't mean you haven't got another one. So I think we will get there with pathogen identification. But for me, it's virus versus bacteria and illness severity that will be the real game changers at this early stage, within 15 minutes if possible. I'm afraid clinicians are very impatient, and so are patients. So it's about timeliness of that test, and obviously high sensitivity and specificity as well. Not asking for too much from you all. And a key question, obviously, within this realm is how we're going to fund and pay for this. Then we think about the use of tests, triages, pathways, and thinking about how can we best optimally treat patients with infection in the community environment? What can impact length of stay, productivity, reduce admissions, improve accessibility, efficiency, and the effectiveness of care within, and bring together quite disparate areas. We have same-day emergency care, we have OPAT, outpatient antibiotic therapy intravenously administered. We have hospital, home, and virtual wards, and we have infection hubs. They're no use separated. We need to bring them all together around common principles. And that's what we're trying to do nationally. And I implore you to think about doing regionally and locally, because without that, we are not going to become greater than the sum of our parts. And then effectiveness initiative will be lost. The hubs themselves might be places where we can coalesce to join all of this up. As I said, 363 was set up, about 730,000 patients. The average cost per appointment radically reduced, and the volume of patients that were seen was staggering. It reduced pressures on primary care, it reduced pressures on the emergency departments, it improved same-day access. And these large-scale system changes are going to be really important to consider going forward if we're going to really maximize our chances of providing optimal care across the NHS. The new sepsis guidance, again, is another example of what we need to look at to think about how we influence and reduce just-in-case prescribing. It asked two main things. How sick is the patient? B, what is the likelihood of infection? And then put on a scale of a treatment urgency based on that graph. So if you're in the top right corner of the graph, you got your antibiotics immediately. But if you weren't, there was an opportunity to wait, to watch and wait, send tests, get more opinion. And illness severity provided that sort of link with how quickly we gave treatment. So you're always able to give antibiotics urgently if your clinical judgment decreed and the patient was sick. But in a well patient, you probably had a bit of a window. It was good for hospitals, probably good for ambulances, but at the moment not fit for the community. So the question is how we reframe this for the community, because 80 to 85% of all antibiotics are administered in community settings. News 2 is not widely used in the community, so we've got to think outside the box. What else can we put in place? Does it mean that when patients have a suspected infection, they should get, for instance, a News 2 physiological score? Should patients with suspected infection be seen in infection hubs where there is more capacity to do News 2 scores, where there's more ability to do tests and identify the organism? These are all big questions, and questions that can only really be answered with good research. And this is our opportunity. NICE have really come on side and started trying to put themselves more in the clinician's footsteps or boots, where you don't know the diagnosis, where you have someone who presents with some pretty undifferentiated symptoms, and then you've got to sieve them and decide what's wrong with them. And this is what the suspected acute respiratory infection guidance published at the end of last year really helps us with. It doesn't say this is a pneumonia, this is what you do, because that's not real life. Real life is you have a patient who has a cough, they might have a fever and a sore throat, and you're trying to figure out what's wrong with them. That's where our guidance needs to start, to be really, really useful in terms of the coalface and on the shop floor. They made a few research recommendations thinking about point of care tests, antimicrobial usage, all things that are mentioned in the bid and all things we need to really think about. The ambulance tool across all ambulances is a good starting point for what perhaps needs to be stood up. NICE haven't quite got that far, and hopefully over time they will get further towards helping us with this really large undifferentiated area. The acute respiratory infection hubs have gained funding to look and specifically at impact, but also to get to the heart of some of these antimicrobial questions in terms of usage, but also stewardship. And then thinking about broadening this model, about whether we can then expand what we are thinking about from infections across all other conditions and presentations is a really exciting one, because sometimes it's not easy to tell whether someone has an acute infection or not. So we have this competition, we have our opportunity, and I've listed these in 4 main areas, and it's far more complex than that. But thinking about number 1 and our novel care delivery methods opportunity, we potentially have this model of prevention, presentation, acute care and outcomes, and thinking about where that first element goes, it is in that large scale system redesign potentially, and then thinking about the data that underpins it. Secondly, optimizing the use of antimicrobials with decision tools is really where the clinical assessment part fits. With News, with Pews, with Muse, with various other tools and red flag symptom decision-making algorithms, and then the use of point of care diagnostics and susceptibility testing to actually think about the testing within that acute care setting. And then last but not least, what we need to do from a prevention and control perspective to radically improve outcomes for patients. So I will stop there, and I really hope that's been useful. I'm very happy to take any questions. Thank you.
Thank you very much, Matt, for this. It was an excellent presentation, and you set a little challenge for our listeners today, which I think is fair. So I like your wish list take-home message for them. And we do have some questions for you. And also, Michelle, if you don't mind to come on camera as well, because there are some questions about that maybe you might be able to address as well. And I will start with one from Joseph that probably is, and just to say, Jonathan also is thanking you for the excellent presentation, Matt. But Joseph was asking if the infection prevention and control focus area extend to the development of vaccines against AMR bacteria.
If that's for me, yes, absolutely. Prevention is a massive area. We are actually trying to move towards a more infection prevention and management type approach rather than purely considering AMR in isolation, because AMR doesn't exist in isolation. AMR is one small but really important element of infection management, and it's critical. But everything we've seen in the paper is all about how you better optimally manage infections, and that absolutely includes huge amounts in prevention. There is well, I could have shown millions of slides today, but there's a slide where we try and sum up all those opportunities in terms of prevention, training, and training is not just for staff, it's for patients as well, and empowering patients with the language of sickness, and communication and behavioral insights and behavioral modification of both patients and clinicians. All of that links with a prevention and management type approach.
Thank you, Matt. And just, Michelle, maybe coming to you to check for this specific call, how feasible it would be to think about a vaccine, maybe.
Exactly. Yeah. So I was just going to chip in and say, yes, it's not excluded, but you just have to be mindful of the limitations of the awards. So our phase 1 awards are for 6 months and up to 100,000. So if there are activities you can achieve within that time that address your aims, then by all means do apply. But these are hard limits, I'm afraid.
Thank you, Michelle. Yeah, just to set a bit expectations in terms of what we can achieve with this call, and then obviously what is needed. Thank you so much, both. And then we have a comment and a question from Jonathan, another Jonathan, but Jonathan Sneaker. And I think it's for both you, Matt, and then Michelle, maybe to chip in. They have a product at Atto Marker, which is in late stage development with a proof of concept, point of care rapid multiplex test to be launched on benchtop and handheld devices. And this provides results from a finger prick blood collection device on three biomarkers, which is indicative of either bacterial, viral, or co-infection cloud data enabled. Basically, they want to understand if something like this would be of interest for this call. Matt, what's your comment first?
Yeah, no, definitely. I presume, is this an MXA-based viral indicator, or is this purely about specific pathogens? Because I guess the only thing that makes me shy away from specific pathogen identification is the fact that it could be many different bugs, essentially. And what we found increasingly over time is that people that do particularly badly are co-infected with several viruses, not just one. And, you almost have a pick and mix type approach. If you've got 6 viruses that are pathogenic within a specific patient presentation, what do you test for? How do you know you have actually excluded everything? And, which is why I'm kind of, at the moment, leaning more towards, is it bacteria, is it virus, and is this going to kill the patient, as being the 3 critical questions, I suppose. So, I think we will get to a point, perhaps with a panel that can cover 99% of pathogenic viruses or bacteria, for instance. And that might be the best we can do. But the question in terms of the finger prick approach, absolutely. Very fast turnaround, absolutely critical. And the ability to do it from the back of a car on the road when you're visiting a care home in the middle of the night would be a game changer.
Thank you. And Michelle, do you want to come in terms of the type of innovation and just say something more broadly about that? Oh, you're muted, unmuted. Yeah.
Yes, not too much further to add in terms of that. Innovations at any stage are welcome. This is primarily phase 1 to support early stage technologies because we don't have a set entry criteria. We are open to innovations at a more developed stage, but please do check as previously what is feasible within the time and what it is you actually plan to do with the award and demonstrate the potential impact from that.
Thank you. And just to the attendees, I see that there is a lot of activity in the chat. I can't read the chat, so if you have a question for our attendees, do use the Q&A box, please. Otherwise, I'll miss your maybe very important question. Thank you. Another question, I think this is more for you, Matt. Do you see novel therapeutic mechanisms as playing a major role in prevention? And the attendee says, for example, virulence factor inhibitor drugs to prevent opportunistic bacterial infections occurring in hospitals.
I don't think we can rule anything out as being of use. We need to cast the net wide in all angles. As long as whatever we're doing is pragmatic in terms of clinically possible, then I think it's our job to explore them. I'm not sure we can close any avenues off. And I'm sorry, that's a rather woolly and imprecise answer. But I would just urge people not to be restricted in their thinking. And for you as a panel to be not restricted in what you give money for. Because we're not going to get anywhere by making the same mistakes thousands of times over with infection care management and AMR, which is what we've done up till now. We need stuff out there that is potentially going to break the mental model if we're going to really make the inroads that are needed. This is not the last pandemic of our lifetime. And every winter we get an infection pandemic that almost breaks the NHS. The substrate is there. So the challenge is there. This has been our biggest killer for our species since time began, and we have still not broken it and fixed it. So cast the net wide, be ambitious, and don't give up.
Thank you, Matt. And I mean, that's as much as you could say on this. Absolutely. Thank you. And actually, I know maybe if you have a quick answer to that. Someone was asking about where the acute respiratory infection hubs are in the UK, because you mentioned some in your talk. Are you aware of how people can find information on those?
There is a national work stream and forum on the Futures website if you have access to that. But there are programs leads working in the urgent emergency care. We can find contacts after the meeting to put you in touch. But we do have a map identifying exactly where every single ARI hub is in the whole country. But essentially at the height of it, they were in every single ICS. And this is when we had 363 running. So across all 42 integrated care systems, essentially, it may have reduced. And, you know, I know that it's probably been more persistent, shall we say, in areas of deprivation compared to not areas of deprivation, and probably more concentrated in areas of urban living versus rural or coastal at the moment. But what's crazy about it is when a good idea comes along, you can't predict sometimes how it's going to spread, be shared, or implemented. So it's well worth, you know, getting some more feedback, and I can try and dig up some contact emails.
Thank you. Yeah, that would be useful. And maybe the listeners interested can send us an email in our SBRI inbox and we can provide the information afterwards. Thank you so much. And let me give you a break, Matt, and maybe I'll direct a couple of questions to Michelle, and thank you for taking this action. There is a question from Jyoti, I don't know if I pronounce your name right. I'm sorry about that. But if can the feasibility study be for new innovation features of a product that is already being sold to customers? Michelle, do you want to comment?
Yes, so we're open to studies looking at the feasibility of new innovative aspects of the technology, or even looking at new settings and repurposing technology. So yes, that will be valid. Again, assuming they meet the challenge brief and eligibility criteria. Thank you.
And do you mind maybe to comment as well? Surav was asking about if they are allowed to use subcontractors and if they have to be based in the UK. So do you mind to tell the audience about this?
Yes, absolutely. We welcome you to include expertise that addresses all aspects of your project, whether this is within your team at your organisation or through subcontractors at other organisations. And we do have space on the application form for clinical partners or other subcontractors. In terms of whether they have to be from the UK, no, assuming they are justified and appropriate, they can be a company outside of the UK. To note, we do allow applications from the UK or Europe. If they're broader than that, they need to be subcontractors and they need to be justified. Again, also noting that we need to see evidence and benefit for the NHS and care settings within this country.
Yeah, thank you. Because yeah, one of the aims of the program is also about the national economic growth, although obviously, you know, to address the challenges, the first key aim. Thank you. And then there is a question that probably can be addressed by both of you from different angles. Noticing that the ARI season starts in October onwards, but our contracts will start probably in January by the time we finish all the process. So the attendee was asking if they could miss some crucial evidence and if we have any suggestions on that. But before maybe we comment, just a reminder that you're only going to do a 6-month feasibility study. So also to set the expectations towards what you can achieve. But maybe Matt, do you have any comment on that?
I'm so sorry. I was reading the chat.
So never mind. So maybe I'll repeat the question and maybe again Michelle also to chip in first. It's about our, let's call it misalignment with the acute period for ARI. The season starts in October, but our project will probably start in January. And so the audience was asking whether there would be a missed opportunity to collect crucial evidence and if we had any suggestions to address that. Michelle, do you want to maybe go first and then Mark can reflect if there is anything he wants to add? Go for it.
Yes, so just from our point of view, unfortunately, our timelines are set. There's quite a lot of processes within the commissioning cycle that we have to fit in. So unfortunately, we'll have the panel towards the end of the year. So as Katrina said, we won't be able to contract or provide announcements by October. Also, just to add on the point that she mentioned in terms of the feasibility of what can be achieved within the 6-month phase 1. On that note, I just wanted to highlight if anyone is planning any studies involving or that would require ethical approval, please do consider whether they would be achievable within the time, noting that we'll have outcomes at the end of the year, contracting during January, and projects will need to start from then, just to ensure they're all finished in order to start a follow-on subsequent phase 2 study subject to budget. So unfortunately, not too many suggestions from me, but hopefully Matt can chip in with something clinical. Thank you.
I mean, you're right in terms of, I guess, the numbers, but even in January and February, the numbers are still high. In fact, still in June and July. So in the depths of summer, acute respiratory infection was the most common reason for turning up as an emergency admission in my unit. So I think whatever time we do this, it's still going to be busy. And we did a prevalence study to look at the emergency department attendances with acute respiratory infections. And this is staggering stuff. It's about 15% of total patients arriving in emergency department have a suspected acute respiratory infection. 15%. It's just incredible. And that's all of the emergency departments in England for the whole year. So whilst we do get a doubling in winter, it's still the most common reason for turning up. So you'll still have loads of patients to potentially study, and it may be a bit more manageable with slightly less patients, ironically. So there is a kind of bright side to this, if for want of a better expression.
Thank you. And I see, Matt, that you were typing an answer to one of the questions. Maybe we want to respond live. So this attendee was asking, how does surveillance for AMR in hospital care currently work? And is there any environmental monitoring to assess potential AMR load or circulating pathogens and so on? Do you want to articulate here, maybe?
Yeah, I mean, there's pretty exciting stuff from... We're trying to create, well, we've created an AMR dashboard nationally that was hosted by Palantir, but now is within the kind of NHS England architecture. You have to apply for access as an acute trust or community provider, but then you can see basically what your resistance rates are against some key pathogens and the incidence of infection, specific bacterial infections in that regard. It doesn't quite fit the whole purpose. I think one of the massive challenges of AMR has not been the AMR bit, but is contextualizing AMR against the total incidence of infection. Because what you really need to understand is not necessarily just the AMR rate or the AMR numbers, but how many infections we're actually seeing and what the proportionality of AMR is within those infections. And then you have a more grounded view on, I guess, the impact of interventions to reduce AMR, for instance, or what the trajectory is AMR relative to the total growth of infections, because infections are growing rapidly. So us standing still within AMR in terms of total numbers of cases is not necessarily a bad thing. And that's what we've got to also understand, because sometimes we set very ambitious targets within AMR that are not achievable based on that activity, based on the growth. And as a result, we just need context to better understand it. Secondly, in terms of environmental, we did some rather interesting work with wastewater to look at basically the load of antimicrobial resistance we are seeing in wastewater. There's also river sampling that's going on. These aren't publicly available dashboards as yet, but there is future potential. And the question, I suppose, is, certainly with us adopting more of a One Health approach, so thinking about agriculture, the global impact of AMR and the growth of AMR against the total infection burden, it gives us this unparalleled opportunity really to start thinking about the influence of climate, environment, and the way we build healthcare facilities on AMR, and how that varies geographically and geopolitically. Both in this country, but across the world. So it is a work in progress.
Thank you. No, I thought it was useful to discuss so that people could have an overview, because it was quite a broad and interesting question. Thank you, Matt. And I think this next question can be for both of you. You can start, Matt, with the vision, and then Michelle can chip in for our perspective. But would specific hospital-based decision tools be viewed positively, or would this be regarded as too niche based on also what you presented and your excellent vision you have expressed? That's what the words say, so I'm referring that to you.
I don't think it's a bad thing to do. It's absolutely what we need. It's such a gray area is the problem. So there is variability about how we manage patients in all settings, when we send tests, who we send tests on, and the point when they occur. And you only have to look at the implementation of procalcitonin nationally to understand that variability. We are not always extremely well evidence-led as clinicians and as systems. And we are very nuanced based on the personalities and individuals that are the post-take ward round consultant, for instance, or the department that is doing it and the experiences they're in. So the more standardization we can have, the better. And, there are good decision-making resources that host pathways. And I don't mean to advertise, but things like MicroGuide, where you can see, where you should be in terms of deciding what to give and when to give it. And it's how we build the evidence into those at scale in a standardized manner and then monitor for variation that I think is really important. So NICE is kind of heading towards this place, but isn't there yet. And there is a real gap in the evidence market as to what we should be doing and when we should be doing it, which is why I guess the NICE guidance on ARI, for instance, that was published recently is so full of holes. It's not comprehensive. And they've asked for further research here. There is massive opportunity. And there's also available funding from all sorts of funders to actually get to the heart of those NICE questions. So in your applications, think about what else is in this sphere, what other questions are being asked, and build that compelling case for why you need the funding.
Thank you. And I think, Michelle, in terms from our perspective, do you have any comments?
So I guess it's just building on those last couple of points from Matt, essentially. So you'll need to demonstrate the potential impact of what you're planning to do. The reviewers will look at that. So it's whether there is potential to broaden it, and also looking at whether it's competitive. You know, are there similar existing ones in other hospitals, other settings, that maybe it would be better to improve, or why is yours better, and what could it achieve, I think.
Thank you very much, Michelle. And there are still quite a few questions, so I'm going to grill you two a little bit longer, if that's okay. There is one, I think, yeah, maybe for you, Michelle, probably. The SK 985, which is a very interesting name. Can I confirm that LA Public Health teams are able to apply for this, please? Can you expand on that?
Yes, absolutely. Any organisation is eligible to apply. So we just ask that you are the best person for your project to apply, and that you have a mind to the route market of any innovation that you are developing. So yes, we welcome your application.
Thank you for clarifying. And now we have another sort of eligibility question that you can both comment on. This attendee has developed a system that is capable of killing all known pathogens in the air, which is transformational. This is now fully operational and is ready to start on-site trials. And it is incorporated via air handling systems. Would this qualify? Off you go. Matt, do you want to comment on that?
Interested to hear more, that's for sure. And, you know, I think based on the evidence, if there is early evidence over where it's being trialed and the impact that it has, I think it's potentially quite exciting, yes. So bring it on, let's find out more.
Michelle?
Yes, I think I agree. Without further information, it's not entirely clear to say. However, you mentioned it's ready to start on-site trials. So I guess, again, it's this question of what would you be planning to achieve within this 6-month phase 1 study, and also ensuring what it is you're doing aligns with one of the sub-challenges of the brief. But if there are aspects that are feasible within the study, again, you can demonstrate the need, and then yeah, give it a go.
And also you can reach out to our email address if you want to share more confidential details with us, if you have more questions. But Michelle, isn't this a good opportunity to remind about ethics and the process and some challenges that innovators have encountered?
Yes, so I think I did mention earlier within a previous answer, but
okay.
yes, please, just to reiterate, do be mindful of the timelines we have here. So it's quite a short outcome due diligence contracting start process. So this isn't a competition where you have a 6-month lead up to get everything in place. So if you do have partners, please ensure they're engaged at the start, ready to sign agreements promptly. If you require ethics for any work you're doing, ensure you can get the ethics approved as well as the study completed within the 6 months without necessarily particularly long lead up. So yes, do really consider the feasibility of your work planned within the restrictions of this call.
Thank you. And I have another maybe sort of eligibility question if you both want to comment, if it seems in remit. So this organization is developing nanocarriers for therapeutic delivery. They had results showing intrabacterial delivery in gram-positive and negative bacteria, and they want to explore the business case regarding enhanced antibiotics delivery on different levels. They're not developing new antibiotic, but just providing enhanced delivery and want to understand if this could fit the call. Matt, do you want to?
I mean, yes, anything that improves your ability to treat infections is got to be within this. I don't know enough about the bid process to understand whether it would be a high priority and qualification, but it would fit effective treatment arm, certainly of the mental model that I have in my head about how we need to go forward. So nanocarriers are an exciting area. We still don't know enough really to understand their full role forward, and we do need a great deal of research to actually establish that. It's an exciting potential area and relatively untapped.
Thank you. Michelle, anything to add? Or?
Nothing other than saying yes, if it was something that fitted within the remit of the call and the practicalities, then we would welcome it.
And yeah, then there is going to be an independent panel anyway of experts that will assess each application. So it will be ultimately their decision to what to prioritize. We have another question about, again, Vikram as into bundle approach diagnostic point of care. And can this be a potential project that can be funded? Can acute respiratory hub help with the research? So Matt, I think this is more for you.
Absolutely. And that certainly in my head is the way forward. We need to differentiate sick people. We need to differentiate people with bacteria versus virus or non-infection. And a diagnostic bundle linked to a clinical pathway, a decision-making pathway, would be the nirvana of that. We've got to remember within hubs, they're not all going to be doctor-led. Some of them will be, you'll be seen by a nurse, advanced nurse practitioner or another healthcare professional. So we need to create sensible pathways underpinned with the right timing points for when a point of care test is required and the influence that carries in terms of the decision-making over whether an antibiotic is given or whether an admission is recommended. So all of that lends itself really well to the bundle approach. And I think from a location perspective, an ARI hub is a perfect place to do it because you've got the scale and you've got a degree of standardization of collecting data and hopefully an ability to link that data with the hospital. So I remember the earlier question about, is January too late? January is too late to start the conversation about how I'm going to get data linkages or things set up. There's a great deal of underpinning work that could be done prior to the onset of this funding to link the data elements. How am I going to get end-to-end research from this, from community all the way to the hospital and then out the other side? What conversations do I need to have? What agreements do we need to make? And once you start to pull all that together, then you can start delivering really good, potentially exciting quantitative outcomes against some of these initiatives.
Thank you. That was very useful. And conscious of time, I think I have one last question I want to raise to you, Ma, before we close this Q&A session. And there are, I know, some other questions we haven't answered, but we have a session later on Q&A, so we can answer those later, don't worry. Luke was flagging that the discussion is currently seems very community and emergency based. Presume you also consider interventions in hospital care. What's your view, Matt, in terms of the importance of those?
Very much so. I think there'll always be a captive audience in a hospital in terms of not only the prevention and the management, but also the care of very sick people with infection, with sepsis, etc. But my bent, and I work in acute care, I see really sick people, and I'm mainly hospital based. In my experience, and this is probably a bit biased, the stuff I do feels important, but I think your big opportunity potentially is in the community or the bits before to really make the difference, to make the intervention, both in terms of prevention, preparation, but good chronic disease management. And I often see or feel, rightly or wrongly, that by the time they get to me, it's almost too late. And, you know, this is why I suppose my energies up till now have really focused on how do you intervene at the earliest point possible, at the first onset of the first symptom, particularly in groups that are particularly vulnerable to infection. What can you mitigate? What can you put in place to both prevent but also potentially reduce the impact of infection at that early stage? Because I'm a firm believer of getting in early, both in terms of your assessment management in an empowered, educated population. And by doing that at the earliest point, you will deliver best outcomes. And time again, and certainly I've worked in some really deprived areas, getting to patients too late that arrive with really high news scores, really severe acuity, they're just never going to do well. And I think hospitals are really, really important, but perhaps the biggest opportunities in the bit before.
Thank you very much for that. And this doesn't mean that we wouldn't accept your application. But obviously your thoughts can bring us to think a little bit more broadly. So thank you very much. And maybe to touch on one point, other people were asking if we are prioritizing different areas for this call, sepsis or any other infection, urine infection, wound infection, respiratory. And actually, the call is quite open. So maybe to touch on that point as well, hopefully this answers both questions. Okay, so Michelle, anything to say before we conclude?
I was just going to say the call is quite open, although it does specifically highlight those 4 areas that have been identified, addressing UTIs, respiratory tract infection, sepsis, surgical site infections, particularly within the diagnostics monitoring and AST. But yes, if you can demonstrate potential impact, patient benefit of your innovation, then, and it fits within the challenge brief, then please do apply.
Thank you. Thank you very much. So I think we can close this Q&A session. I want to thank Matt for joining because I know he has to go to more important endeavors now. So thank you for making the time to talk to us today. Michelle, you're gonna stay, so we'll see you later. But thank you, Matt. Thank you very much.
Thank you very much.
And now we can move on to the next speaker for today. So if we can go to the next slide, please. Just one second. There we go. We have Dr. Rusty Naseem. She's a program manager for economic growth at the Northeast and North Cumbria Health Innovation Network, and she's going to talk a bit more about the work that they can do to support you. Thank you.
Thank you very much, Katerina, and a really interesting morning of discussion. Good morning, everybody. My name is Rusty, and I am a program manager in the economic growth team for the Health Innovation Network in Northeast and North Cumbria. So I'm going to give you a bit of background about what the Health Innovation Networks are, what we do, and how we can help support your application. So next slide, please. Oh, sorry, next slide as well. Thank you. So who are we and what are we? So we are the HINs. There's 15 of us across England, and we were previously named the Academic Health Science Network, so the AHSNs, and we're sort of spread all across England. And we were established by NHS England in 2013 with the goal of spreading health innovation at pace and scale. We work with innovators sort of across the country and worldwide, trying to break into the NHS markets. And the main objective we have is to improve health and generate economic growth. So we work with a range of healthcare organisations and businesses to support the spread of all types of innovation within the NHS, from new technologies to ways of working and service improvements. And we do this to improve services for patients and to enable NHS efficiencies. We're also seen as the innovation arm of the NHS, and we are the interface between industry, academia, health and social care. And the majority of the work that we carry out is commissioned by NHS England and the Office for Life Sciences. Next slide, please. So where do we work? So we work locally and nationally. So Where I'm based in northeastern North Cumbria, for instance, this is our local area. However, as I mentioned previously, we do work with innovators sort of across England. So you don't feel that you need to get in touch with your local sort of health innovation network. We can always redirect sort of innovators to the most appropriate network if we feel that's best. So what we do is we identify innovation and improvements to specific problems. So we do this by working with local integrated care boards and partners in order to understand unmet healthcare needs and priorities, and then to co-design and co-deliver sort of innovative solutions. This creates sort of an innovation pipeline. We also empower innovators to further their ideas and connect with the right stakeholders. So we have a good track record of linking innovators up with the right resources and getting that key feedback from a range of experts, whether that be sort of healthcare professionals, regulatory experts, etc. We advance the uptake and spread of innovation and improvements by delivering national programs. And these are sort of programs with agreed national priorities, and that enables rapid sort of scaling and uptake across the board. And then nationally, sort of our goal is to bring all of us HINs together. So bring the sort of connected network of 15 of us together to deliver transformation at scale. So we collaborate to make nationally important innovations visible and accessible sort of throughout the NHS. We want to make a greater impact, to highlight successes and sort of share best practices and what works and what doesn't work well, just so we can continually sort of achieve change on this wider scale. Next slide, please. So at Health Innovation North East North Cumbria, what do we do? So we work with the North East and North Cumbria Integrated Care System and our member organisations. So for instance, the NHS trusts that are sort of local to the North East region and the universities across this region as well, to help them to identify, evaluate, adopt and disseminate transformative innovations. And that would be the same sort of practice for each of the health innovation networks across England. In all of the work that we do, we do seek to improve health outcomes, to implement processes that are safe, that are continuously improving, engaging industry to generate growth, accelerate digital transformations, and to develop NHS innovation. So we essentially do this with our innovation pathway, which I'll go over in the next slide, and we help companies to access expertise across the NHS and sort of build strong relationships. So our collaborative partnerships transform research into clinical practice, and in order to improve health outcomes and address areas of unmet need. So here's a little pictogram of the innovation pathway, which is bespoke to North East North Cumbria. So a very detailed sort of map of getting your idea and getting it into full scale spread and adoption. So how do we use this? We use this pathway to articulate sort of the bespoke services that we can provide to support you as innovators to create and develop, commercialize your innovations and have it adopted by the NHS. So as you can see, we have 5 sort of key gateways from idea assessment through to spread and adoption. And each gateway sort of in the hexagons has subcategories where we feel evidence is needed in each of these areas to kind of build you a robust portfolio to then have that innovation adopted. And what we can do, we can help with commissioning delivery partners that are experts in each of these areas from the regional healthcare infrastructure that we have, to support us in the provision of services. So for example, organisations that would be able to provide expert feedback, health economics. We have in-house a team that are able to help design and build a real-world validation study as well as clinical trial studies. So sort of whatever works for you and your innovation. And this pathway as well, I just want to highlight that there's no early or late stage. You can come to us at any point. So if you feel that you fit in at Gateway 1 or Gateway 3, we'd love to hear from you. Sort of, we can help sort of build evidence that, kind of throughout this innovation journey. So next slide, please. So how can we help? So myself and my colleagues at Health Innovation North East Northumbria sort of have a good background in AMR. We're aware of the current landscape and sort of the guidance published by the government, and we have an awareness of current trials and studies, sort of emerging innovations and possible sort of unmet need gaps. We'll be able to help with application reviews and development advice, link you up to the right people to give you some sort of feedback, whether that's sort of clinical or again regulatory. We can do an innovation review to understand the unmet need and the help required to build that portfolio of evidence. And I think the key thing is we have a spread and adoption toolkit, which will enable us to help you sort of create a business plan and, you know, the fundamental kind of strategy to help implement your innovation and get it into the NHS for future commercialization. Next slide, please. So what happens next? So if you have sort of any questions, sort of please do get in touch with us. We'd love to hear from you. I've linked in sort of our website, and then there's 2 email addresses that you'd be able to reach us on. As I said, and I just want to reiterate, there's no sort of early or late stage to get in touch. If you feel that anything of what I've presented might be applicable to you, please just drop me an email and we'd be happy to help. And next slide, please. So yes, if you have any questions, please do pop them into the Q&A box, and I'll try my best to answer them, or just get in touch. And I'm very looking forward to hearing from you all. Thank you.
Thank you, Rusty, very much for this overview. And at the next Q&A session, no worries, I will grill you a little bit with the questions that will be asked in the Q&A box. But last but not least is another SBRI Healthcare team member, Dr. Danilo Villanueva Navarrete, who's gonna talk a bit about the assessment process and how you can apply. So he might answer some of the questions you have asked in the chat already. Thank you, Danilo.
Thank you, Katerina. So yes, we're going to talk about the assessment process and how to apply. So as it has been mentioned already, this is a phase 1 that can lead to a phase 2 process, and this is how it goes. So it starts with an application. It's a good reminder that the call is open since 17th of July. So it's open to everyone, and it's a short application form online. After the close of the call, this is going to go through a process of shortlisting that is going to be reviewed by a pool of clinician, technician, and commercial experts plus the PMO, where there is expected to have up to 25 applications shortlisted. After these applications shortlisted are going to go to a panel meeting where they are going to be invited to provide a 3-minute video pitch, and it's going to be reviewed by a panel of clinician, commercial, technical experts, and patient and public representatives. After they have made their decision, this process goes through due diligence and contracting. So once everything is clear and all sign up, you will expect it to start your phase 1 project, as Michelle was mentioned earlier, up to £100,000 and during 6 months. Now, for the start of phase 2, which is a closed call, only successful phase 1 projects will be invited to participate on phase 2. Which consists on a detailed application form online, including PPI strategy, which is going to be peer review. This application goes to a panel meeting that consists of a 15-minute presentation with Q&A with the same panel composition. Again, after the decision of which projects get funded, it goes to another stage of due diligence and contracting, and then the start of phase 2, which is up to 800,000 in maximum 12 months. And hopefully after that, your technology will be reaching patients, NHS, and sales. So what is the assessment criteria we are expecting on this stage? So I'm not going to read all this information, but it's available in our website, and I'm going to say where in later stage. But what is important for me to highlight here is that the criteria has different percentage. So when you do your application, have this in consideration as well, and goes from how well the application address the challenge brief, the project plan, how innovative is your solution, commercialization and implementation plan, equity of access, net zero, your team composition, and as well the cost. So what are the key dates we have to have into consideration for this phase 1? As I mentioned, it has been open since the 17th of July. and is closing on the 28th of August at 1 p.m. Cannot stress that 1 p.m. enough. The assessment is going to be during September and October of this year, and the selection panels will be in November of this year as well, with expectation of contract awarded for January 2025. Right, so leaving that aside, let's tell you how to apply if you're starting from zero. So the first step is to go into our website, which is sbrihealthcare.co.uk, where you will be able to see on the top a tab that says competitions, where you can click on open competitions. So for this example, we have competition 26 stroke, but obviously we are here for competition 25 AMR. So if you click for read more, you will be able to open the website of the competition. When on the left side of it, you will be able to see the key dates of this competition that I mentioned. The main text of body will give you a brief of what is the goal and the sub-challenge, but not in details. And at the bottom of this text, you will be able to find really useful information, which is, first of all, the links to guidance for applicant and phase 1, the portal guidance, and the FAQs. Is really important information because many of the questions you may have, you will be able to find an answer on this document. But as well, at the bottom, you will be able to find some supportive documents, which is the invitation to tender that, for example, goes into detail of the previous slide that I mentioned, the challenge brief, which go into details with what is the challenge and what are the sub-challenge that will help you, for example, to know which sub-challenge is more adequate or aligns better with your technology, the template application form, the finance form, and development agreement. So the development agreement is our contract, and it's very, I really suggest you to read this first before starting efforts in your application because our terms and conditions are not negotiable. So with that, and where you can find this useful information, you can start your application. So you click in the very top, you will see application portal login, will take you to this RMS system portal. So if you're an existing user, obviously you can go straight. But if you're a new user, it's very important to pay attention the message that it says that is we endeavor to be able to complete this process as soon as possible for you and your colleagues because it takes time to validate the accounts within standard working hours. So we cannot stress this enough to do it as soon as possible. So regarding if you're a new user or an existing user, you will be able to go and to manage my details and you will be able to update your CV. It's very important to have this information up to date because some of this information will be extrapolated in your application. So that's why it's important for you to have this information up to date. But here, after that is done, you will be able to click in a new grant application, which will take you to this page. So here, in this example, we have SBRI 17, but you will see all the opens competitions and click on competition 25 AMR. From there, you will see that the application process, you will be able to see this screen. Where you on the left, you will see all the section and as well information that can help you with guidance prompts to complete these sections. It's not necessary to do this in one go. You can save and complete it later, but just be mindful of the dates as well. Once you start doing your and completing your application, you will know that there are a section for team members or collaborations or subcontractors. So that will require to be able to put your teams into the application. So to making this possible, your collaborations or your team members that are from your organization, they will have to have an RMS account already created. So that's why have in mind this process can take time. Once they have created their account, you will be able to introduce them in your application to select them as part of your team members or collaboration. And how they see from the other end, once they have been as a co-applicant, they will be able to go into their section to My Co-applications, and they will be able to confirm their participation in your project. It's important here to note that they need to confirm the participation to finish your application. So if your application by the 28th of August at 1 p.m. has not confirmed all the participants, your team members or collaborators have not confirm their participation, your application will not be able to go through. Thank you very much. Kate, back to you.
Thank you, Danilo. Thank you very much for this overview. And remember, 1 p.m. submission time. Danilo stressed it very well. So if that's okay, I'm going to ask Michelle and Rusty to go back on camera so we can start the second Q&A session. So people, please do continue asking questions in the Q&A box. And in the meantime, I think I'll start with one that we left from the previous session and was for Michelle. And if there is already good evidence of efficacy, if this funding will still be eligible for exploring other aspects of the innovation, such as market, PPIP, net zero, or does technical feasibility needs to be also addressed? Michelle.
Yes, so all those activities you outlined are eligible to be completed within the phase 1 application. I think, again, it's really a part of stating your case and making the impact for having all this additional information to progress your innovation and what the next steps are to progress it towards patient benefit.
Thank you. And I actually wanted to ask a question for Rusty, because you did provide a link for innovators to reach out and talk to you. Do you mind to take us a little bit more through the process of like what happens when they reach out, and also if there is any particular information that it would be better that they gave you at that stage or later? So if you have any insights on that.
Yeah, of course. So generally what happens with innovators is, so we would route you into our navigator inbox, and they would send you out a document where you fill out sort of all the details about your innovation, the evidence you've obtained, where you think your next steps are, because sometimes it's good to get a clear overview of where you think you are as an innovator versus how we think you are. And then what we would do is have a Teams meeting with you, and just to kind of go over and discuss sort of the next steps and where we think evidence could be built and generated, and how best to then progress with applications. If work has been done in a specific part of the country and there's an unmet need in a particular area, we could then sort of refer you. For example, if you came to us, we could route you down to the southern regions if we felt that was a better fit. So the engagement form is sort of, it gives you a clear outline of all the evidence that kind of we think that you might need to gather. So it asks about regulatory aspects as well. If you've got a digital innovation, about DTAC, it grills you a little bit about your innovation, but I think it's needed just to kind of help us to understand how to help you best, really.
Thank you for that. And I'm going to jump on actually the last question that came into the chat, the Q&A box. Sorry, not the chat. I'm not looking at the chat, remember. But it's about if there is any requirement to look at the to work with the Health Innovation Network, and if people are less likely to be successful if not. And maybe, Michelle, do you want to touch on that, and maybe Rusty, you can also explain why it would be good too. Yeah.
Yes, absolutely. So it's not a specific eligibility criteria that you have to work with a Health Innovation Network, but we do recommend it just because of the breadth of support and advice they can provide, and the link into the NHS and all their support and advice. But I'm very happy to hand to Rusty to really emphasize all the benefits you can get out with partnering with them, either just for advice or actually inviting them to be a part of your application.
Thanks, Michelle. So yeah, just to go into more detail. So so when you do sort of initially contact us, there's no sort of charges or anything associated with that. All our advice is free. We're funded by NHS England. But again, just to echo what Michelle was saying, if there are any sort of bodies of work that we can help sort of facilitate with, we can be written into grants to help those. We've been part of a number of successful sort of applications to SBRI grants, and our expertise in-house, I would say, are pretty, we're pretty knowledgeable about AMR and the landscape. So I do feel sort of working with the Health Innovation Network can get you sort of the right links and kind of make your application sort of more robust.
Thank you both. And moving to one that maybe is more for Michelle at this stage. Darren is asking if we will look favorably upon neonates and adults, in particular neonates in neonatal care. I think it's more broadly in terms of what we favor for this call, if anything. So go ahead.
Sure. So we're not specifically favouring any aspect of this call. We've outlined the key priorities within the challenge brief, and so long as you address those and can demonstrate your impact, these will be reviewed by the committee. To note, there is one particular priority referring to neonates with suspected sepsis that has been highlighted within the challenge brief. But we're open to innovations that address all ages and all populations.
Thank you. And again, I think one for you, there are quite a few specific ones in terms of the details of what we found, I think, following Danilo's presentation. And one is about if we cover overhead costs and if it is 20% of the staff budget that we would cover. So do you want to explain?
Yes. So we do cover costs required for the project, so this can include overheads. We don't set it at 20%. We expect all applications to come in and will be looked at in terms of fair market value. So reviewers will look at the value for money for proposals. So we are open to costs such as that, but we don't have set guidance on amounts you should request. That's up to the organisations to determine.
Thank you, Michelle. And I think I'm going to bunch up a couple of questions here because they are all related to budget and volume of projects. So someone was asking how many projects do we expect to fund for phase 1? And someone else was asking what's the total funding pot for phase 1 and phase 2? So maybe we want to discuss that.
Sure, and I'm afraid I've got to be vague on both of those. So it depends on quality. We don't have a specific budget ring-fenced for this phase 1 AMR competition. We all fund quality applications. I can say the previous phase 1 competitions, we typically fund around maybe 9 or 10 applications, and this is per challenge. So we're also running a phase 1 in women's health. So we will fund applications across both.
Thank you. And we do have some questions about subcontractors. I'll ask again, maybe we can give a bit of a speech around the 3 of them, but someone is asking if subcontractors need to be invited or if they can be added to the project later, and if all of them need to confirm their participation. Also, by participants, if we mean each team member or is sufficient to have one representative per organization. So do you want to unpack this? It's a bit, you can, yeah.
Yes.
I'm happy to help.
I was going to say there's quite a bit in there. Let me know if I've missed anything out. We do recommend that you include all key partners within the application form. So do invite them to the application, and they will need to accept and approve their role within the application. This also provides reviewers with confidence of the support and engagement from the subcontractors you have. If you're successful, there will be more discussions around this during due diligence. For instance, we'll be requesting final quotes, subcontract agreements, whatever's appropriate for the particular relationship and body of work. So yes, please do include all key partners and get them signed up on the RMS. I think there was a question about outlining all members. So we do need to know who's going to be involved in the project and have costs against them. If you don't have specific named people at this time, obviously that's key, but if you're recruiting to a specific role, then you can include that that's to be confirmed at a later date. Apologies, Kate, please chip in if I've missed anything.
You gave you a different task, which you addressed very well. I think on the, also just to add on the each team member, nominating each team member, if you're working with a subcontractor organization, it's better if you at least name the person that's gonna be key responsible for a particular work package. Then obviously you also don't have an unlimited space to mention all the collaborators. There is a limited number, so you can't name each single person in the organization, but it gives confidence if they have accepted their inclusion in the bid. So definitely include them if you can, at least one named applicant. Okay, thank you. And I think someone is asking, I think this maybe we can answer, we can reiterate this even if we have answered before, but the company wanted to ask whether we have any recommendation on universities versus SME. When both are involved, should we further focus and task to the SMEs to maximize the impact with commercialization opportunities in the NHS? So I guess what they're asking is who should be the lead applicant, maybe? Yeah.
And I think that depends on the project. So we are open to SMEs or universities or other organisations as lead applicant as appropriate for the project. As we've stated, we aim to be an SME-friendly programme, so we do want the contract signed quite rapidly. If you're at a university and you know there's some bureaucracy and it can take time, perhaps it is more appropriate for the SME to lead, but we have no preferred lead applicant type. Another thing to mention, as you say, we want to be able to see that there is a clear route to market or plan. Obviously, the developed stage of that plan depends on where you are in the pathway. You may just be at the very early stage, but it should be in your mind for how eventually your innovation will get to market and to patients. So yes, advise who is ever best placed for the project and the innovation.
Thank you, Michelle. And we have also a question about from Arthur, I guess, if the funding is targeted at new innovations that are not yet a commercially available solution. Can you give a steer?
It depends on what your plan is. Typically, yes. But if, for instance, you're repurposing from a different area or developing it further, there is potential that it could fit within remit, but I think we'd need more information to fully answer that. And if anyone does have any specific questions about their plans, you are welcome to either send us an email or join the Q&A in October, where we'll also be holding breakout rooms to discuss your plans in detail if required.
Yeah, thank you. And I think because we don't really have an entry point, but it's a lot about how do you really meet the brief. So, and it depends on the project you want to do. So absolutely, Michelle, thank you. And I think Rusty, probably your organization is very well placed to support people in this sense, right? So how would you suggest that they came about engaging the Health Innovation Network for these specific questions?
I think if you sort of just email us and sort of kind of outline the details and direct them to us, we can kind of provide some further details and clarifications.
Yeah, thank you very much for that. And I think we have a couple more questions here about phase 1 and phase 2. So maybe let's crack on with that. Someone was asking when phase 2 projects would start, because it's important for them to take into account when they plan phase 1, and then On top, we have also a specific example of what a project phase 1, phase 2 could look like. I'll read that later, but you want to explain a little bit, Michelle?
Yes, in terms of timelines, so the timelines for any subsequent phase 2 are not yet set because it all depends on the annual budget we receive from NHS England. So I can't provide a definitive answer. However, I can give you a steer that last year's phase 1 in child health will be finishing in October. And we really do try to aim for the phase 2s to continue straight on with that. So we do have, finishing in August. We do have to have the phase 1 finished before we can close the application to phase 2, because obviously we need to see how the phase 1 studies finish before you're starting phase 2. So subject to budget and approval, there's likely to be a few months between the end of your phase 1 and the start of your phase 2. But we do aim to fit the commissioning process in straight afterwards.
So will the application process start during phase 1? Someone is asking, just to clarify.
So we aim to give you as much time as possible. So we will likely open the application to phase 2 before your phase 1 has finished, but we won't close it until after your phase 1 has finished.
Yeah, because the outcomes are important also for the phase 2 assessment and for the feasibility of your phase 2 project, right? So we wouldn't close it before.
Exactly.
Yeah. And there is, again, around this, there is a question on a specific question from before about still nanoparticles. And Vikram was asking if nanoparticle with natural fiber for infection is of interest. And is collaborating with University of Birmingham and Aston University. And he was asking if it needs to be a large data set for this study to be concluded for phase 2 from phase 1. So
I'm not entirely sure what you're asking there.
I think, so the question I think is about, firstly, if the innovation is in scope. And I think we need more information on that, but on paper, potentially yes. And the other thing is about what sort of, if we have any expectations on how large the data sets have to be for them to be able to apply for phase 2. I would really like that.
Yeah, again, that's sort of project dependent. So you would need to complete within your phase 1 study whatever is required to complete your plans for phase 2. You do have to include an outline of your phase 2 project within the phase 1 application. So the reviewers do have an indication of your broad plans, but there are no expectations on specifically what you have to collect within your phase 1 application.
And I think this addresses another question about the expectation for phase 2 projects. They're asking if they are expected to end in regulatory approvals and adoption, or they can end in readiness for clinical trial. And I would say all of the above is acceptable, right?
Exactly. I think it really depends on your entry point to phase 1 and phase 2. As we say, we get a range of innovations that starting points for them. We do have in the slide sort of an indication of potential exit points for phase 1 and phase 2, but again, they're just a guide and we don't have any set exit criteria for phase 1 or phase 2.
And there is a matter of feasibility, right? Consider you're given 6 months to have a tangible outcome and then another 12 months to have another complete outcome. So you really need to think about what is feasible for your innovation in that timelines more than anything, not trying to fit to potentially set expectations, but actually we would like you to tell us what you think is feasible for you to achieve. And I see a question about people coming from the US, and maybe Rastia will also come to you after to see if there is any support available from your side as well for them. But they say, my company that manufactures the innovation is based in the US, but we have a UK intermediary or a UK distribution partner. Is it okay for me, the US manufacturer, to be the lead applicant and for the UK distributor to be the second applicant, or does it have to be the other way? What do you think?
So unfortunately, you have to be based within the UK or Europe to be a lead applicant. So if you apply as a US organisation, you would not be eligible. We do a bit of due diligence on the lead applicants if successful, and during the process. So we do look at the ability of the lead applicant to carry out the work outlined, but unfortunately we're not open directly to applicants from the US, but they can be included as partners or subcontractors with justification.
Thank you. And Rusty, is there anything you want to say in terms of the support? These people seem to already have a footstep in the UK, but do you have any idea of support for others that don't?
Yeah, so we have worked with sort of similar partnerships where sort of the innovation or idea has come from outside of Europe, so you know the States, Australia, etc. And then there is a UK partner who would be sort of the the owner of the the rights for distribution in the UK, and we do work with sort of innovators in that sense to help them then break into the UK market. So yeah, I guess another thing would be to email us and we can kind of outline how we might be able to help and then navigate sort of the regulatory landscape and kind of map out the evidence that you already have outside of the UK to then try and break into the NHS market.
Thank you. That's very helpful. And Michelle,
Sorry.
did you want to come in again?
Yes, can I just follow on to that?
Yeah.
Excellent last point from Rusty. Just to say again, if you are applying from sort of outside the UK and NHS system, it can be really valuable to make sure you have NHS clinical champions or clinical partners on board to ensure your innovation really does fit within the NHS ecosystem in this country.
Thank you. Very good point. This is NHS England call, so a reminder. We have, so this we answered. Okay, again, I think that this is we have a follow-up question in terms of the exit point. So is there a certain timeline that you expect the technology to start being commercialized post-project completion? And is there a certain return on investment that you expect us to demonstrate? Good question.
We're very happy for as soon as possible and as big as possible, but we have no set guidelines for timelines for different stage gates. As I mentioned, we have innovations coming to us at differing stages across the pathway, so we don't set any specific hard lines there. You will have seen from the early presentation that we do get a high number being commercialized, entering into the NHS and bringing back return on investment. I think in terms of funds we put in and private investment leveraged, I think it's almost £4 something for every pound we put in. So there is a lot going on. So great when you do achieve it. But we don't say you have to do that immediately within or straight after our funding.
I mean, it would be good, you know, for a good success story for us, but understanding that that's not always possible. We have another question about what sort of activities can be covered in the project. So this attendee is asking if they can apply just for hardware development under this project. If you have other aspects of your overall product development covered, for example, the lab validation, PPIE, commercialization, including stakeholder analysis. So how broad has to be, I guess, the project in terms of activities?
Interesting. I couldn't see that question. But yes, I think as Katerina hinted at there, if you can demonstrate broad work packages that you can achieve within your application, noting the limits on time, then that may be looked favourably upon. So we're really looking at the impact of your work on progressing your innovation towards patient benefit. But development is an eligible activity within the project. So you mentioned, I think, PPIE. Again, we do see that as a key aspect of any project we run. So it's great to have patients and public involved all the way through the design process.
And let's not forget, I guess, also net zero, right?
Yeah,
yeah, that could be just, you know, a little policy important topic right now, but maybe something to consider as well. You can use this as an opportunity to demonstrate how you meet the carbon ambition of the NHS as well as part of the project if it fits. So, yeah, thank you. We had just a couple of questions. One, I think it was more of a comment from previous conversations where we met, but I wanted to flag it anyway. We were talking about giving support to community, but Grace was flagging that also giving funding to GPs should be discussed. We can comment directly on this in terms of Matt's vision, but I guess what we could say is that funding to support GP practices as part of projects can be included if it makes sense for your project to do so, right, Michelle? We don't necessarily have to focus on community.
Yeah, exactly.
Yeah. And we have only one last question, which is an interesting one. If a project can apply having their primary commercialization plan to be in the US, followed by the UK later. Do you want to have a stab at that?
Yes, so you really do have to demonstrate within your application your plans for the UK and benefit to patients within this country. However, we do note that organisations need to be sustainable, and perhaps the NHS is a small market, so one of many you may be targeting. So it is okay for you to have plans more broad than the UK, but we do need you to outline your aims for growth within the UK.
Yeah,
apologies, I've just forgotten the other point I was going to say.
Well, I guess it's not a no, like it's absolutely fine if you have plans to go abroad, but we need to see benefits in the NHS, and this is what you're going to also generate as part of evidence. So don't disregard that. If you do that, it wouldn't really align with what we're trying to achieve, if that makes sense. I think that we have answered all the questions that we had lined up. So well done us.
Can I just,
yeah, go for it.
Potentially one we missed on PPIE.
Oh, sorry. Yeah, fine. Go for it.
So the question is, within the application in terms of what you're putting in terms of for PPIE, if you already have a patient advisory group of part of another project, which could be used to support this project too, is there a requirement to cost more PPIE work within this project application, or can we comment on how our current PPIE work is relevant? So just to answer that, we don't say you have to cost in for PPIE if you've got funds elsewhere, but we would expect to see an outline of your plans for patient and public involvement and engagement within the application. And please do include in your justification if these are being costed elsewhere, as if we see planned activities but no costs, then that may be a question. So long as you're doing work that's relevant for this project, we wouldn't double fund, so we don't expect you to cost in work that's already being covered elsewhere, but we would expect some PPIE work involved.
Thank you, Michelle. I missed that, so thanks for flagging. And we have a second question about how we pay projects. We pay them in advance. Yes.
Yes. So we may split it into two payments, but we do pay upfront. We don't wait till the end of the project to pay applicants. We're well aware, particularly for small organisations, that that may not be feasible, and they benefit from payment before they have to pay to any subcontractors or do the work. So yes.
I'm loving the standing ovation you're getting for this answer. So, yeah, good. Okay, thank you. And I think since there are not many other questions, probably we can draw the Q&A session to a close. And I wanted to thank Michelle and Rusty for really powering through it until the end. Thank you so much. And before you go, please bear with me 2 more seconds, because I have something very important to say. It's not over. The support from us continues. And after you have digested all this information that we gave you today, we are hosting on the 8th of August a Q&A drop-in session. So you can come at 2 p.m. You have to register. The link will be on the slides and on our website. So you need to register to attend so you can receive the link. But please do come along if you have any other questions, or you might want to have some more in-depth discussions. And also a suggestion to be aware about all our initiatives. You might want to subscribe to our newsletters. We don't spam you, we just send communications when we have really something to share, either a new competition or an event. So do take the time to do that, so you will make sure that you don't miss anything that we are doing if you think it's interesting for you. And I think that's all from us today. These are our contact details. We are either a phone call or an email away from you, so do contact us whenever you need. And Michelle, did you want to say something?
I was just going to say thank you to everyone for joining and for your questions. Hopefully it was useful to you, and good luck with your applications. We look forward to receiving them.
Thank you. Thank you, Michelle, and thank you all for staying with us until the end. Have a nice rest of the day. Bye.